So hello and welcome once again to this morning's webinar on brain health and with an active lifestyle. My name is Natalia Rodriguez and I am the bilingual education specialist here with PSS Circle of Care. For those of you who might be new to us, a little bit about PSS. We are an innovative multi-service agency whose mission is to strengthen the capacity of older New Yorkers, their families, and communities to thrive. PSS Circle of Care provides free support for those who are caring for someone who is frail, chronically ill, or is experiencing memory loss, and for families where a grandparent or a family member other than a parent is raising a grandchild. The free services that we offer are consultations, support groups, education and training such as this one, wellness events, respite opportunities, supplemental services, information, assistance, and advocacy. For further information about PSS and the services that we provide, please feel free to contact us via the email and the phone number that will be posted on the chat box shortly. Just as a reminder, this webinar is being recorded and will be posted on our resources page at pssusa.org/events and on our YouTube channel. Should any questions come up during the presentation, we ask that you please submit them in the Q&A section of your screen for an opportunity to have them answered by our panelists during the Q&A portion of our event. We are joined this morning by Dr. Rebecca Lassell. Dr. Lassell is a licensed occupational therapist and assistant professor at Indiana University School of Public Health, Bloomington, and at Regan Street Institute affiliated scientist. Dr. Lassell seeks to design interventions to support brain health and health equity. Her work focuses on bridging the gap between community-based services and healthcare systems while seeking to understand how factors such as social determinants of health, chronic disease, and function shape a person's ability to access healthcare and participate in health promoting activities they find meaningful within their homes, neighborhoods, and communities. Dr. Lassell's research interests include exercise and lifestyle medicine, gerontology, health equity, hospice, and home health care. So Dr. Lassell, thank you so much for joining us this morning and for just presenting for us. I'll turn it over to you for the rest of the presentation.
Fantastic. Thank you so much, Natalia. I'm so happy to be here. It's such an honor to be able to spend the morning with you all during this time. And I hope to, hopefully this information is helpful to you. And I'm excited to discuss things with you at the end during the Q&A. And I also have some discussion questions for us throughout the presentation where I'll be asking you to put your responses in the chat, and then hopefully after I can answer any additional questions you might have. But yeah, without further ado, let's get started. So just a heads up, I have no conflicts of interest to disclose. The research that I'll be sharing today was funded by ClinStar, a ClinStar Pilot Award funded under the American Federation for Aging Research. And the views are my own, not ClinStar's. So I want to make sure I say that up front. So our learning objectives today, we're going to define what green activities are. We're going to discuss the benefits of green activities in relation to healthy aging and brain health and reducing risk for memory loss. I'm going to share some findings from a study I did last year where we co-created the Green Activity Program to promote health and well-being and brain health, and hopefully mitigate some of those risk factors for accelerated cognitive decline. And then I'm going to share some information about the feasibility study we have that's going on right now in case anybody is interested in learning more or potentially joining the study. So to start out, to put in the chat, I want you to think about what kind of activities that you enjoy doing outdoors. And I'll give you a second to think about that. And then I'd love if you could share that in the chat. So go ahead and share for those of you who have one that popped into their head. Awesome. We're getting so long walks every day. Yes, walking, hiking. Love that. Basketball, that's another good one. Those are all great activities. I also like hiking as well with I have two little kids. Well, they're not little anymore, excuse me, 7 and 4. So they remind me constantly that they're older, but I enjoy hiking with them. Yoga in the park, that's another great one. Very cool. So it sounds like a lot of you are already doing some outdoor activities, which is really exciting. All right, so thank you for sharing that, and we'll move on. So let's talk about the types of nature or green interventions. Shanahan and colleagues lumps them into two separate categories. So one, there's green or nature interventions that seek to alter the environment where people work, play, recreate. And examples of this are gardens at hospitals, or putting parks in parts of the city, like park beautification in parts of the city where there isn't. And then there is also green or nature interventions that seek to change behavior. And that's where my work falls mostly in this space, the changing behavior piece. And so examples of these types of interventions can be, and when I say interventions, it can be programming, activities, experiences. Examples of these can include like gardening programs. It can include walking groups. It can include outdoor yoga or outdoor basketball, those sorts of things. And then when I talk about green activities specifically, there's a couple of different ways to define them. The way that I think about them, as they're talked about in the literature, are they have these three components. One, they're meaningful to people or they enjoy doing them. They involve some sort of social element and then an element of nature, whether that's just being in contact with some greenery while you're doing the activity, or it could even be in your home, having like a plant nearby while you're doing an activity. But combining all those three aspects in the social piece is how I think about green activities or any type of activity or physical activity in contact with nature. So there's a lot of activities when you think about them and define them that way. I think about them in these 4 different buckets. So activities with animals, this can include walking a pet dog, bird watching, fishing, outdoor exercise. So outdoor yoga, basketball, walking, hiking, biking, outdoor recreation, gardening. This could be tabletop gardening at home, could be, doing yard work or pruning your flowers and stuff outside your home or apartment as well. But it can also include community gardens. And then conservation and sustainability activities. So this could be like tree planting, volunteering in your community to create green space, do park or beach cleanups and composting projects. So what do these activities have to do with health and well-being, and why should we kind of start paying attention to them? So thinking about health, and on this slide, I want to bring up how I think about brain health as well. And this definition comes from the World Health Organization, but it really focuses on the state of how our brains function across all of these different domains. So cognitive, so how we think about things; sensory, how we experience the world around us; social, emotional, behavioral, and motor domains that really allow us to reach our full potential over the course of our lifespan. And this is irrespective of whether or not we have chronic conditions or the presence or absence of a disorder. So when you think about it, there are things we can all be doing throughout our lifespan to be promoting our general health, but also our brain health, which is a piece of that as well, and is very interrelated to our other domains of health, I should add. So when thinking about brain health, I don't know if you all are familiar with the Lancet Commission's report. They have a report that comes out every few years that looks at modifiable risk factors. So risk factors that we can modify or change throughout our life. And I believe they have a list, it's like of 12 or 14 that we can play with and modify. And if we do that, they predict that potentially up to 40% of Alzheimer's disease and related dementias can be modifiable, that risk for them. And then the other risk, can be related to genetics or other things as well. So when we're looking at later in life, some of these risk factors that we can work to change, and the area where my work focuses is looking at physical inactivity. So particularly sedentary behavior, sitting, which I'm doing right now, and I know some of you might be as well. But also looking at that social isolation piece, so trying to reduce depression as well. And then thinking about diabetes is also on the list there, and air pollution and smoking. Air pollution is harder to modify, when we think about what we can personally change or control. But things like physical inactivity, social isolation, getting out, staying active, that can improve risk of depression. Risk factors for Alzheimer's disease also go hand in hand with risk factors for diabetes and cardiovascular disease. So when thinking about modifying these things, a general guideline and rule of thumb is anything that's good for your heart is also good for your brain. So many of you probably know this already, but just thought I'd put it out there. So let's focus a little more on that physical activity piece. So there's been a lot of work done looking at, if we're staying active, can we reduce the risk of dementia? And physical activity is a great way to mitigate that risk factor because you're using the capacities that you have and hopefully staving off some of those declines. So how much exercise is recommended? This comes from the World Health Organization, particularly for older adults and older adults living with chronic conditions. They recommend 2 a day of aerobic activity. So that could be, taking care of your garden or lawn, walking your dog, riding a bike, doing yoga, staying active there. And then they also recommend resistance training 2 times a week. And thinking about ways to build that into your daily activity, that could be carrying your groceries home, from the store, as like going to a gym is not doable, for everyone, especially if you're providing care to someone. You have to think about, sometimes it requires creative problem solving of ways to think about how can I build some of these things into my daily activities and routine, which is one of the spaces I'm interested in with my work. But these are their guidelines. And then, thinking about, we know these guidelines are hard to hit. About 23% of Americans meet the physical activity guidelines. It's harder for older adults, particularly women and men. And then when we look at physical inactivity in the US, and there's health disparities there as well. So we see high rates of physical inactivity in Black and African Americans, people who identify as Hispanic Latino. And then as we look at age, obesity, disability, or a presence of a chronic health condition, we see that physical inactivity continues to increase. And so the World Health Organization, their guidelines are, let's just replace any type of sitting with any type of activity, physical activity. So that's where my work comes in broadly. And I know this is a busy infographic and slide, but there was the study that came out recently that looked at sedentary behavior. So that's like sitting activities versus, staying physically active. And if you replaced 30 minutes of sedentary behavior with any type of activity a day, we see that the risk and incidence of dementia decreased, and then also the risk of dementia mortality for individuals who already had a diagnosis. So now again, there's all sorts of, when looking at research, there's all sorts of things that can be considered there when thinking about, what diagnosis someone receives at the time of death, as far as like what's the main cause. There's all sorts of factors, and it might not be the best outcome measure, but still, I felt like those numbers were pretty powerful, and this is something that's fairly simple to do, just replacing 30 minutes of sedentary behavior with any type of activity, can have a huge impact, whether you have Alzheimer's disease or you don't. So I thought that was really powerful, and that's one of the outcomes of my work that I'm hoping to move the needle on. So looking more specifically at the health benefits of green activity. So one of the questions is like, why do green activity versus regular activity or physical activity? There's been some research that has come out that has shown doing activity in contact with nature can lower anxiety and perceived stress beyond indoor and outdoor physical activity without greenery. And as far as like dose, like how much is needed to like move the needle to make a change, one time a week for at least 30 minutes was found, just like being exposed to a park, going to a green space, was found to increase physical activity, increase social cohesion, and decrease depression and high blood pressure by 7 to 9%. So again, just being exposed, like going to a green space or park, can have these amazing health benefits. And then when we're looking at benefits of green activities specific to people living with dementia, we know that green activities with animals, gardens, and exercise can have these benefits, specifically emotional well-being, forming social connections, supporting physical and cognitive function. We also see increased physical activity, and then decrease of symptoms like anxiety, frustration, loss of appetite, apathy, those sorts of things. And they can be meaningful to people, which to me is one of the more important things. So knowing about the benefits, there's also a lot of barriers when we think about who gets to access parks and who has time and resources to do some of these activities. And when thinking about people living with dementia, there is there is a shame and stigma associated with dementia. So that can be limiting in and of itself for people wanting to go out and be in nature or be involved in nature programming. Also, we see physical barriers as far as like neighborhood proximity to green space and parks. And this is due to redlining, but also park accessibility and walkability. So just because you have a park close by doesn't mean that you can access it or feel safe and comfortable being there. And then also, especially during COVID-19, and before, but thinking about different things that have happened recently. There's lots of fear of racism or hate crimes with the political climate. And then I don't know if you all remember, it was right after George Floyd, but in Central Park, there was a African-American man who was bird watching, who was accused of kind of, taking a white woman accused him of kind of taking pictures of her, or she called him in for just bird watching. And so that, the racism and fear of hate crimes, like that's a real thing that occurs across places. I'm doing a study here in Indianapolis, and that's like come up as well. So it's all over, and it's something, it can be a big barrier. Then there's also this notion of the park paradox. And this work, Erica Weiss, not Erica Weiss, Dr. Weiss's work comes from New York City, but it's this idea of in New York City, there's like a lot of parks, right? A lot of parks and playgrounds, and New York City prides itself in like there's a park within a 10-minute walk of most New Yorkers, which is great. But despite having a park nearby, we're still seeing this paradox, especially of lower physical activity, especially with parks, because they've noticed there's lots of parks around Black and Hispanic neighborhoods, but we're not seeing people going out to the park. So what's going on? Well, after doing some research there, they found that these parks, there were lots of barriers to people feeling safe and like comfortable to actually being in the park. So things like adjacent neighborhood disadvantages, like maybe higher rates of crime, lack of traffic safety. This is a huge thing that has come up in multiple studies that I've done where people have talked about concerns or fears of like not being able to cross the street in time to like actually go to the park. And then also toxic land use, people dumping trash. Or I know one of the parks I lived really close to in Bay Ridge, there were like syringes and like all sorts of like things that you would not want to touch or be exposed to in that park. So those are some of the barriers there. And then when someone living with dementia is actually able to access the park, they can experience barriers in actually participating in a group activity or just in an activity that they want to do. So thinking about especially the earlier stages, we see folks with fluctuating levels of function. So, one day they might be able to remember their walking route and the next day they can't, or there's good days and there's difficult days depending on multiple factors about how they're feeling and that sort of thing. And also thinking about a lot of people have more than one thing going on, right? So it might not just be difficulties or challenges with memory. It could be they also have arthritis, or there's some physical conditions they might have as well, like a wheelchair, walker, that require extra modifications for activities or adaptations. And then another barrier too is a lack of dementia-friendly education and training to safely include people living with dementia in ongoing nature programming that's happening in our communities. So I'm going to throw another question out to you all. And my question is, has there been anything that has made it difficult for you and your loved one to do nature activities in your community? So I'll throw that out to you. And if anybody is interested in putting something in the chat, feel free. And if not, I can share. Oh, great. We've got one. Let's see. Inertia. I love that. All right. Safety. Yeah, that's a big one. That actually came up where can't walk. Okay, yes. So that can be a barrier as well. All right. Well, thank you all for sharing those. We'll come back to those when we talk about designing the program. Oh yeah, people smoking. Yep, that can happen. Traffic and pollution. Yep, that's another big one. Well, great. Thanks, you all. These are awesome barriers, and we'll talk about them later on as I present findings from the co-design session here. Oh, and I forgot I have an extra question. What has made it easier for you? Has there been anything that has helped or made it easier for doing nature activities outside? And if you can't think of anything, that's okay. City sponsors yoga in the park, but only in spring and fall. Okay. So it sounds like having sponsorships, and support from outside organizations to do these events. But again, it looks like another potential barrier there may be the seasons, so like spring and fall. And we'll talk about that too, because that's something we've been thinking about a lot as we're doing this program. Well, great. Well, thank you. All right, let's see here. So next I'll share findings from a green activity program that we co-designed this last year with people living in the Bronx who identified as Hispanic Latino who were living with memory challenges. And I recognize there are many different terms that can be appropriate to describe people from Hispanic origins. We asked our folks what they wanted to be called and what term they felt best described them. So I'll be using Hispanic Latino as a result. And we also asked them about terminology as far as like what they wanted to be called as far as memory challenges, Alzheimer's disease or dementia, memory loss, and memory challenges was the term they chose. So we'll be using that as well in our talk today. And before I present these findings, I just want to share a little bit about me and why I've been interested in health equity work. So I've been an occupational therapist, oh gosh, for about 10 years. And one of my first jobs out of school was working, I worked in several different long-term care facilities around Indianapolis before I moved and did my PhD and postdoc. And one of the things that kept coming up, because I worked in more affluent parts of town and then parts of town with lower resources. And one of the facilities I worked in, we were like on lockdown because we were in a part of the city that it wasn't safe for people necessarily to go outside. There wasn't any green space. And the folks I worked with too came from all sorts of different backgrounds with lower resources. It was primarily a Medicaid, Medicare facility. And as I was doing my job as an OT, I remember one man like really stood out to me. I went in his room and he was in tears. And he felt so depressed. And so we talked about, like, well, what can we do today? And he chose that he wanted to work on dressing. So we set a goal, we're going to work on dressing today. And we worked on it and his mood brightened and he really like came out of his shell and he was smiling and laughing. And I loved his sense of humor and his tenacity and just, he was fantastic. But I left that session feeling like I was putting a Band-Aid on a much bigger problem. And as a clinician, I could temporarily help people feel better in the moment, which is important, right? But I wasn't addressing the broader circumstances and the broader challenges that he faced. And so after having him and multiple other patients in that facility that had that same experience, I wanted to contribute more broadly to how can we change some of these social determinants of health and factors that are contributing, to these difficult situations and how can we make people's lives better. So I wanted to contribute more broadly to health equity work, like how can we provide equal resources for people to be able to achieve the same health outcomes, regardless of race and ethnicity or socioeconomic status, and those sorts of things. So that's been my why for doing this work, and also recognizing the power of being able to do an activity you enjoy and how meaningful that can be, and how it can be a source of identity, and how it can connect us to other people as well. So I'm going to talk about my project that's going on in the Bronx. I also have a green activity study in Brooklyn with Chinese Americans. It's currently paused, though. I'm about to go on maternity leave. So putting a pause on that for when I come back. This project's going to stay rolling. I have the staff infrastructure to do so, but thinking about prevalence for Alzheimer's disease and related dementias, we know that it's 1.5 times higher for individuals who identify as Hispanic Latino, and it's projected to increase the most in this group over the next few years to 2050. And when we're thinking about risk, it can increase for individuals living with lower resources. And now there's many reasons why, like there's not just one risk factor. People are trying to figure out, like what's the magic thing that can make this change? And it's a complex problem, right? It's not just one thing. And one of the reasons why that may contribute to this is just, we need more education, we need more supports, but we also need to be including people from Hispanic Latino groups and from other groups too who face health disparities in these spaces. We need to include them in designing programming or interventions that actually meets their needs and helps them feel welcome and speaks to their cultural values and that sort of thing. So there hasn't been a lot that's been developed by asking the input of people living with memory challenges from this group. So that's what my work was hoping to address here. And we talked broadly about green activities, but really the three components, being meaningful, having an element of nature, and that social piece. Green prescriptions, which is the process of prescribing a nature experience, an activity, or basically those things, exposure to nature. It's been occurring in 17 different countries around the world, and it's primarily been used in primary care settings for individuals with risk factors for heart disease, more of a preventative, type measure. And also with children and youth. And so my idea in this study was we know that nature activities can be beneficial to people living with dementia. Let's apply that idea to that, because in the past, nature activities for that population has focused on just one specific activity, and that's not necessarily doable for everyone. Not everybody likes to do gardening, for example, and it's not always available to everyone. So I wanted to think about how can we do a broad green program, that could include the diverse interests of people living with dementia, and offer different options that really truly meet their needs, interests and needs. So that was the idea behind this study. And to help this happen, we're having an occupational therapist deliver the intervention. And again, this is in part because my background, I'm an OT, and as part of our scope of practice, what we do is we tailor activities based on someone's level of function, their preferences, their needs, and the context, their daily situation that they're in. So that was the idea. But more broadly, this could happen across professions in the healthcare industry, but this is where I'm starting in this particular study. So we applied a community-based participatory research approach, which involves acting with our community partners, assessing how it went, reflecting and refining. So we acted in this study to create the program. And now in the second study, we're assessing how it goes by trying it out. But basically, we co-designed with 3 different groups from our community, people living with memory challenges and their study partners or care partners who identified as Hispanic, Latino, healthcare providers, interdisciplinary healthcare providers, so social work, OT, neuropsychologist, geriatrician, and then also people who provided local nature activities in the Bronx. These were our objectives. For the sake of time, because I realize I'm taking a lot of time, we'll kind of skim over them. Basically, what we were trying to find out was we were trying to match like what frequency and duration and delivery mode of the program could work for folks, could fit in their daily schedules, how they wanted to receive support from the OT. We wanted to identify a range of nature activities people were interested in that could then be personalized and tailored, and then outcomes that mattered to people, recruitment strategies, which included empowering language and identifying language that represented the folks in our group, and then referral pathways and fit into clinical care from our healthcare providers. So we developed this intervention to be culturally congruent or appropriate. And what that means, we tailored on a surface level, which means including members from that community on our team, in our recruitment materials, study materials, using language and euphemisms that are familiar to the community. But also deep structure tailoring. And this involves really incorporating some of the values, cultural values from Hispanic Latino culture. So respeto, dignity, perlísimo, famísimo. So perlísimo involves relationships and how, personal relationships are really important in Hispanic and Latino culture, but also family, feeling connected to family, respect and identity for family. And so ways that we incorporated this into our co-design, we tailored our nonverbal cues during co-design sessions. Co-design is a special word for like co-creating something with someone. So we had like a focus group style team that met, and we asked for their input on parts of the intervention. And one of the nonverbal cues that's typically used in focus groups to get someone to stop talking is to not make eye contact. And my team members said, that's going to be looked on as disrespectful, because in Hispanic Latino culture, making eye contact, and especially because they were, my moderators were younger, they were in college, and thinking about the age dynamic too, like to show respect, you make eye contact and you listen. And so they came up with the nonverbal cue of having a special sign, like a wave, or tapping their arm or something as a nonverbal cue to help people stop talking so the next person could answer, which I thought was a really great way to incorporate that. And then we also included questions about including family or friends in the program. And at the end, we've made that an option for people, depending on how they'd like to include, people that are close to them in their lives in the program. I'm going to run through these slides really quick because I recognize we're getting towards the end, but this is the sequence of our design sessions. We designed with outdoor professionals to just get a sense of like what local activities are out there. And then for people living with memory challenges and their care partners, of those activities, which ones do you like? Are we missing anything? What outcomes matter to you? And our healthcare providers gave great input on like research design, outcome measures, and fit into clinical care. So this was our initial prototype of the program with the circle. And then over here with the 2 columns, that's what we ended up with. And what was really interesting is our outdoor professionals asked for a separate arm of the intervention, because a lot of them, there were a couple who did programming for people living with dementia already, but the majority did not, and they wanted to include people living with dementia. So they asked for a site evaluation from the OT to assess accessibility, the types of activities they had. They requested dementia training so that they could learn how to communicate with people living with dementia, and also be able to understand how to tailor activities or adapt the activities they had going on to best meet people's needs. And then they also wanted the OT to be able to be at the first session with the person, so there could be transfer of those strategies in real life and like figuring out if they worked and then tweaking it and then having the OT provide support. And then our column that's white on the other side, I do want to say I drew from, for the frequency and duration of the program, I drew from successful green prescribing programs that are currently happening. And then also my mentor, Dr. Laura Gitlin's tailored activity program, which is specific to people living with dementia. So we did have, like ranges of frequency and duration that we knew worked in the past that we asked people about. And so we got their input on, like what should be included, the duration, how to test the activities, what kind of support people wanted as well. And if sessions should be virtual or in person. So preferred nature activities, key findings, people loved group outdoor exercise like walking or dance. They asked for outdoor crafts and cultural activities like sharing food, music, dance, gardening came up. In regards to our research design and thinking about recruitment, they preferred the terms well-being instead of brain health. They felt like brain health was too confusing. So I actually had taken it out of my presentation and added it in today because I realized that's what us researchers talk about, but in the real world, people don't always know what brain health means. And so emphasizing like broader health instead. And then using the term memory challenges. They were open to using dementia and the specific type of dementia in a clinical setting, but in the community, again, for like respect and dignity, they preferred the term memory challenges. And then they preferred Hispanic Latino instead of Latinx or Latino or Latin or Hispanic. This was the referral pathway our interdisciplinary team came up with. So multiple different ways to refer to the program, including self-referral. And then potential barriers and solutions. So a lot of the barriers you all mentioned came up in our group, like thinking about transportation and safety. Food insecurity was something else that came up. And so potential solutions, utilizing community resources, thinking about creative ways to transport people to these different types of activities, but then also thinking about how can we bring the activity to the person in their home? And so we created a huge list of local nature activities that have like options where you can go in person, options where you can stay at home, or do like something virtual instead to best meet people's needs, and have options for those days where you feel great, and are able to get out, and those days that are difficult and you might not be able to get out. So thinking about that, and then activity, like the main takeaways. And one care partner was saying, these activities can help. And when she goes out, she feels better, she shares more, talking about how it really improved her well-being. And again, this was just like their experience doing activities on their own, we weren't running through the program at this time. So these are just some quotes. One thing that came up for outdoor professionals, and it was something for us to really think through, is like alignment of the green activity program with what was important to them too, because a lot of them, again, did programming for children and youth, and thinking about ways interdisciplinary programming came up, or not interdisciplinary, intergenerational, like ways that there could be crossover that could benefit, they could have benefit from engaging as well. Most though were really interested in that, but that was something I had to think through. Limitations and future directions. So we included people who had self-reported memory challenges. We used the Montreal Cognitive Assessment to understand kind of the range that people were, and we did have inclusion criteria that were limited to before Alzheimer's disease and related dementias, that mild cognitive impairment stage, and then early Alzheimer's disease. So, and related dementias. So that's a limitation. We also had a limited sample for 3 Hispanic Latino groups. So not all Hispanic Latino groups were represented. So that's also a limitation. And more research is needed to determine the most effective methods for including people living with memory challenges in research. We used flexible methods. So for example, we had in-person focus groups for them, but we also offered individual interviews that could be in person or virtual, depending on people's situations, which is a recommendation of the NIA Impact Collaboratory to use flexible options, meet people where they're at. So next steps are the feasibility and acceptability piece. And so this is a flyer for our study. The time commitment is 17 weeks. It's a 12-week program. We do pre-testing and post-testing after the program. And we also are doing a 4-week follow-up. So that's why it's 17 weeks. It involves wearing a watch to track activity for 1 week before and 1 week after the program. We have a minimum of 4 in-person sessions with options to include more sessions for people who need them and want them, and then 2 phone check-ins across that period of time. And we're looking for people for this study who are 60 years or older, identify as Hispanic or Latino, and have memory challenges. And then we're also including care partners. Again, this is early stage. So some of these folks that we've been enrolling are still living by themselves, but we're offering the option to include care partners or a study partner, someone they want to join them in the study. And then I know I don't have a lot of time, but basically the program involves these 3 elements. It involves an OT assessment, coaching and monitoring, so teaching strategies, goal setting to do the activities and tailoring the activity, and then monitoring for sustained behavior change. I'll skip through these assessments. Basically, we're looking at 3 domains for tailoring. We're looking at a personalized delivery to the person and their family, adapting the green activity to the person's preferences, level of function, and daily context. So then an example of what this looks like, we set goals. So there'll be 3 goals to do 3 different nature activities. So this person chose, and this is just an example, this isn't a real person, but an example is walking in the neighborhood, volunteering at Governor's Island to care for animals and do composting, and attending a farmer's market. So they set a goal. And then this is for the person living with memory challenges, again, early stage, but they make a plan to do the activity based on the World Health Organization's guidelines. So we're trying to replace sedentary behavior with this green activity. So they schedule a time, and this is based on behavioral activation techniques, which is one of the most potent ingredients in programs that help people do activities for depression or apathy. So they schedule a time, they try it out, they tell your team, which in our study, it's the OT, the care partner, study partner, or if an outdoor professional is involved, telling them to, and then reflecting on how do you feel, what went well, what didn't go well, what can we change? And then as far as the tailoring piece for study partners or care partners, our Our personalization covers these three areas, so context or environmental modifications where the OT makes specific recommendations for accessibility, safety strategies to prevent falls, or things related to weather if it's really hot or cold or icy, adaptive equipment, activity adaptations in itself, making it easier, harder, and a personalized delivery, making sure we're incorporating the person's strengths and interests and also values in the activities, and having them select the three activities they're interested in, and then assessing these pieces of like supervision, verbal cues, physical cues. And then the idea is the OT teaches these strategies to the care partner or study partner, and then coaches them through utilizing them over the 12-week program so they can continue on their own. And then this is my team. My mentors are on top here. And then Triana, my team member who is doing our intake assessments and recruiting on the ground, is on the bottom, and she's studying for her nursing exam on Saturday. So I'm super excited for her. And then, yeah, here's acknowledgements of all the organizations involved. And that's all I have.